This video presents evidence-based protocols for the clinical management of peripheral neuropathic pain, specifically postherpetic neuralgia, or PHN. It is a modular reference pathway for primary care, geriatrics, and pain specialists. True postherpetic neuralgia is a post-recovery state, driven by structural nerve damage and centralized sensitization, independent of active viral replication. The protocol target is PHN, which occurs after day 120, unlike acute herpetic neuralgia and subacute neuralgia. The incidence of PHN is up to 50% in shingles patients aged over 60. Symptoms include burning or shooting pain, severe allodynia, and numbness. Secondary morbidities include reduced physical activity, poor sleep, and clinical depression. Core principles of neuropathic pain management involve expectation management. Analgesics rarely provide complete relief. A successful trial provides a noticeable reduction in intensity and restores basic functionality. Key steps include documenting baseline pain and emphasizing self-management skills. The primary care treatment algorithm begins with step 1, first-line agents like amitriptyline or duloxetine. If, after a 4-week review, there is no significant decrease in pain and satisfactory increase in physical function, move to step 2, second-line agents like gabapentin or pregabalin. If that also fails, proceed to step 3, alternative/refractory topical agents or specialist pain referral. First-line pharmacotherapy includes amitriptyline, starting at 10 to 25 milligrams at night, max 75 milligrams daily. It carries a high risk of cognitive impairment in patients over 65. Duloxetine starts at 60 milligrams once daily, max 120 milligrams, and requires blood pressure monitoring. Second-line pharmacotherapy involves managing gabapentinoids with a titration staircase. For gabapentin, the dosing increases over 3 weeks. Pregabalin is an alternative if gabapentin is ineffective or not tolerated. Caution is advised for weight gain, respiratory depression, and abuse potential. The pharmacological diagnostic matrix summarizes the drug classes, typical starting doses, maximum daily doses, and duration of adequate trials for PHN treatments, including TCAs, SNRIs, and antiepileptics. Localized therapies for peripheral allodynia include lidocaine 5% medicated plasters and capsaicin 0.075% cream. Topical agents are recommended for localized PHN with severe contact allodynia, but should be avoided in disseminated or multidermatome pain. For refractory pain, tramadol is a weak opioid considered only for acute, short-term rescue therapy. Caution is needed due to risks such as respiratory depression, serotonin syndrome, and geriatric risks like falls and severe constipation. Cross-tapering and treatment switching involves gradually reducing the old drug while increasing the new one, typically over 2 to 4 weeks. Specific taper protocols are provided for gabapentin and pregabalin. When treating geriatric patients, physiological vulnerabilities require modified algorithmic targets. Key considerations include renal clearance, anticholinergic burden, fall risk, and polypharmacy interactions. Non-pharmacological adjuncts, such as physical interventions, psychological therapies, and functional restoration, form part of a comprehensive management strategy. The development of self-management skills in combination with pharmacological options is essential. The biopsychosocial care ecosystem involves primary care managing the core pathway, supported by pain specialists for interventional treatments, neurology for complex neuropathies, ophthalmology for acute involvement, and psychology or psychiatry for coping mechanisms. The clinician's protocol checklist includes confirming the timeline, setting functional goals, executing and reviewing step 1 and step 2, monitoring risks like renal function, and referring to specialists if first and second line systemic and topical therapies fail. Thank you for watching this video. Please like, comment, and subscribe for more insights into medical research and analysis.